Thank you very much for the opportunity to talk today. My name is Gareth Bainham and I'm a clinical geneticist, and most people have no idea what that means. Certainly my kids struggle with it, I think. But basically I'm a doctor. I was initially a paediatrician and then trained in genetics, and really a large part of my job is trying to diagnose conditions, often in children that have combinations of typically quite severe manifestations that might have intellectual disability or problems in organ structure, such as congenital heart disease or many other things. And these conditions are rare, and we'll talk a little bit about that. And today I really want to talk about invisibility. I want to talk about visibility and what that means for public health, and really for global public health, because rare diseases are a global public health priority. Rare diseases are just that, they're rare, but there's lots of them. There's an estimated 7,000 rare diseases. So when we think of them as a cumulative group, in fact they're very common. And the estimates are anywhere from 6 to 10% of the population. And so when we're talking about those sorts of numbers, in fact we're talking about similar numbers to things like diabetes. And if we put everyone with a rare disease together in a country, it would actually be the third most populous country in the world. Now those are the upper level estimates. Now that's 350 million people. Even if we're wrong by a factor of 2 or by a factor of 4, these are still enormous global numbers. In WA, if we use those sorts of estimates, we might be talking about 190,000 people. And these conditions are typically chronic, complex, disabling, disproportionately costly, and inflict suffering. They affect those individuals, they affect their families. Most are genetic or have a very significant, in terms of their cause, or a very significant genetic contribution. Somewhere between a third and a half affect children. So in WA, we're talking about tens of thousands of children. 30% die before their 5th birthday, and about a third of children who die before the age of 1 die from a rare disease. So this is why the European Union, for instance, has identified this as a public health priority and has put an enormous amount of thought and resource into addressing this. So that's my why. That's my passion, is to try and improve the lives of individuals who are living with rare diseases. And one of the ways we have to do that is to try and improve how we make diagnoses. We talk about individuals having a diagnostic odyssey. Because these conditions are rare, a physician or a general paediatrician or a general practitioner may see one or none of these conditions in their entire working lifetime. So that's a real challenge to diagnosis. How do you recognise something you've never seen before? So in one study in the European Union, they looked at some relatively common rare diseases, the sorts of rare diseases that GPs and paediatricians should know something about. Things like conditions like called Marfan syndrome, for instance. And even in that group, what should be relatively well-known conditions, 25%, 1/4 waited between 5 and 30 years to have a diagnosis. And in 40% of those cases, the initial diagnosis was wrong. Now that's for the well-known ones. So I'm going to introduce you in a formula with some trepidation. I know there are mathematicians in the audience. Why? Or what is a diagnosis? And what does that give us? It gives us visibility, it gives us certainty, and it gives us empowerment. It gives us the power to impact on disease progression, the power to reduce complications of disease, the power to improve quality of life, the power to create efficiencies for family units, for health systems, for the community. And also by the very nature of their rarity and the very large signal, the clarity that comes from the extremity of these conditions, they're actually a hotbed for innovation. One, how? Because fortunately we now have a number of new tools that we're adding to our armamentarium to make diagnoses. There have been some fantastic advances in genomic testing technologies, for instance. And these need to be partnered with other approaches. And this is one such approach that's being developed. And I'm talking here about 3D facial analysis. So what you see here is a picture of a commercial bit of kit from a company called 3DMD. There's a number of these in Western Australia. There's about 1,200 of them distributed around the world. And the fact there's so many means we can network globally. We can take, in less than 2 milliseconds, an image. And we actually, if you want, can take 200,000 data points out of an image, but we take about 10,000. The bit of equipment is portable, so you can take it locally, nationally, remotely, regionally, and we've done so. And then we partner that with computing, with algorithms, with people far smarter than me. People like this person. And the reason to do that is so that I look less like that. But more importantly, so we can make these diagnoses earlier and often, so particularly children can get better care. This is one such example of some work done by a really very intelligent PhD student, Stephanie Kung here, who was in the School of Paediatrics and Child Health. And this is just to illustrate a bit of a proof of concept work that we did some time ago. And basically what we did was we've got some individuals with a very rare condition called mucopolysaccharidosis type 1. And we wanted to look at that condition specifically because it can be a diagnostic challenge, but equally there are available treatments for that condition. So we make a diagnosis, we can start treatment earlier, we can improve that individual's individual life. And really what you see here, if I go backwards, is just some visualisations of what are actually very subtle differences. And if you look on the sidebars, you can either see in millimetres of difference here, you can see in statistical units, or you can see in frequency, which bits are more commonly changed in this population. And you'll see in the distance map there, that's millimetres. So again, saying we need high resolution, we need objective technologies to really pick up these subtle clues. This is another way of looking at this, visualising this information. So this is what we call a vector map. And in the grey scale underneath is essentially from our population, from our Perth population, what we expect for individuals that don't have this condition. That's the grey underneath. On the outside you can see little arrows, little bars, and they're again in millimetres, a little sub-millimetre scale. And you can see at the nose there, those little arrows are pointing out. And you can see at the lips there, those little arrows are pointing out. And this is a 3D thing. So we can rotate that through in a 3D space. What we'll see behind the cheeks are little arrows pointing backwards. So that's saying, as far as this computer algorithm that knows nothing about biology, has no clinical experience, as far as that detects, in this objective technique, the nose is full, the lips are full, and the cheeks are sunken in. And the top image at the top showing the face is actually ballooned out. And it's ballooned out because in this particular condition, your body's metabolism isn't working properly and substances build up in the tissues underneath the skin. These changes all fit with what we see in children. They fit with the clinical descriptions. And yet an algorithm that knows nothing about biology has picked those differences. So that was quite reassuring to us in a proof of concept that we might actually be onto something. Now, in the interest of time, I'm not going to go into too many details, but we've also partnered this technology with genomic changes. So how do we actually partner this technology with changes in our gene sequence to give us answers for children and for adults living with rare diseases? Equally and very importantly, the same technologies can be repurposed. We can take these and actually use them to monitor treatments. So I talked about, we specifically thought about this particular condition as it has a treatment. So in another study, we actually monitored the effect of that treatment by looking at the differences in the face using this very high resolution technique. I'm a bit obsessed with faces. I'm obsessed with faces because they're so universal. They're how we interact with everyone since the moment we were born. They're about being, they're about belonging, they're about becoming, they tell the stories of our lives, they're the subjects of art, they're the subject of education, and they tell us about our health, they tell us about our ill health and our disease. And most importantly, from my perspective, subtle facial clues can help to make diagnoses earlier. Thank you.